an increase from 49 members are Medicaid funded, 10 are funded through the Ottawa County millage, and 2 are funded through our Cherry Health Scholarship Program. Part of the evidence-based clubhouse model includes clubhouse members engaging in education. The goal is to improve self-esteem, advocacy, and educate the community on the value of the clubhouse program and reduce stigma around mental health. To further this goal, Lakeside Clubhouse hopes the Ottawa County CMH Board will support the following. First, we're going to have clubhouse members who will be coming to the board meetings periodically to talk about what mental health services mean to them. We really want to help with self-esteem building, public speaking. You know, I'm shaking right now. And so periodically we'll be bringing to share their story. And then secondly, along with other clubhouses around the world, Lakeside Clubhouse will be participating in a mental health week of action in May. We will be hosting an open house on Wednesday, May 24th from 4 to 6. We have some save the date flyers for you. As soon as we get like the formal announcements from Clubhouse International, I'll be mailing those to everybody. So, but they want all of the messages to be the same throughout the world. So just trying to prepare you for that. And we hope that you can come to our house. It'll be fun. Thank you.
I am a member of the Lakeside Clubhouse. I think my international workshop in the activity that made to come how I like to work with staff and other members in job writing, like make lunch, working in the bank and doing computer and looking for a job. While we from the Alpine jail and finding a job to make money to build myself. I think funding from the Lakeside Clubhouse.
I am Julie Boss. Hi. Back in 2015, I was first diagnosed with spectrum affective disorder. For those who don't know, this means I'm hallucinating, hearing voices, and have a hard time functioning and dealing with this new normal. I found myself living with my dad, broke, sleeping a lot, and not participating in the real world. Depression was a big part of my life. Confusion with reality made me difficult to get out of bed every day. My sister Alex heard about Lakeside Clubhouse and recommended me to come to check it out. When I first started coming to the clubhouse, it was a struggle for me learning new jobs, what the clubhouse had to offer and how this place could even help. But since coming, it has pulled me out of my depression because I find reasons to get out of bed every day. Clubhouse has helped me find jobs, and I was starting a new job as a cook and taking care of kids on breaks at kindergarten. I have enhanced my own living skills as I participate in the kitchen unit and learn kitchen skills. I also am working on improving my money counting skills by working in the cafe. My communication skills are improved as I stand here before you reading my story, which isn't easy for me. Yeah, I actually want to say that I'm not very good at public speaking, but I've gotten better with like God too, like has helped me like a lot with it and stuff too, and like better with it. I have become more of a leader and have made new friends from my social circle. I recommend Lakeside Clubhouse to anyone who may struggle with a mental illness or need to improve any daily living skills. Clubhouse has changed my life and I feel so much better since attending. Thank you for listening to my story. Thank you.
Now it's in our boardroom audience. Now we'll go to our Zoom callers. Are there any Zoom callers that wish to make public comment?
Hi, this is Jewel Wickman, Ferrisburg.
Hey, Jewel.
Hi, may I speak?
Yes, go ahead.
Oh, yes, thank you. I wanted to express my appreciation to Terry Goldberg, board member, who asked the question regarding the specialized residential millage funding. He asked last meeting, what are the funding sources for the adult foster care homes, which I'll reference as the group homes? And the answer that CMH gave him was frustrating because I feel that it wasn't a completely transparent answer. The answer given was that the SSI checks pay for the group homes. The SSI checks pay for room and board. However, the caregivers that help with activities of daily living and community integration are paid for through the Medicaid funding that's given to CMH through managed care. So that's what is so frustrating about these meetings. I feel like there's a lack of transparency. Terry was not given a full answer as to how the group homes are funded. So if the CMH decides to cut the CLS services, which are their community living support services, their workers, if they cut the CLS workers or they cut their rates, then the individuals have nowhere to go during the day. And I do mean the CLS daytime. So they have nothing to do during the day. And that's where our millage comes in, where now the local taxpayers have to pay for the social rec centers to give them a place to go. That if budgeted correctly, the question is, could the money be used? Could the Medicaid money be used so that we're not using our local taxpayer money for community integration that is already part of the home and community-based final rule that Medicaid funds? So that's a big frustration in listening to these meetings. I feel like there's a lack of transparency. I feel the answers given to the board members and the people are not completely honest. And also when we listen to the presentations, it's so important. It's hard for me, who follows this all the time, to understand which plans cover what services. So there are several managed care plans that our CMH manages for their recipients, but it's important, they're not transparent as to what plans people are covered under. So if you were to ask the 7,000 people that are served by CMH and you ask them what benefit plan, what Medicaid plan are you covered under, and what services do you get by that plan, I would bet that over 90% have absolutely no clue what benefit plan that they're enrolled in. So therefore, they have no idea what supports and services that they are provided. And additionally, people that are in adult foster care homes or that graduate that have adult intellectual developmental disabilities, they can only get into a day program by a supports coordinator referral. They can't just call ICUS and say, I would like to go.
3 minutes are up, Jewel. If you have
Okay.
more comments, you can do it
No,
at the end of the
thank
meeting.
you. Thank you.
You're welcome. Any other comments?
Yes, Stephen Rockman.
Okay, Stephen.
I'm from Grand Haven Township. Good afternoon. My comment is again about the Momentum Center that gets funds from the community or the county mental health millage, claiming that it is a sound financial investment and financial windfall for the county. And it makes many emotionally good feeling or remarkable claims. My question is, how much of this is legitimate? I think the taxpayers would owe an explanation. The center states that it offers social and recreational programs for people with mental illness, addictions, and disabilities. However, it is not a behavioral health agency. It has no clinicians. Its program coordinators do not need to be psychologists or social workers, but must agree to its diversity and equity statement. The center claims that its expenditures of taxpayer funds has created a windfall for the county. What is the proof? The center claims that, according to research, community is the most important part of maintaining or regaining health. What research is the center relying on? What is the methodology relied upon? How are outcomes measured? How is community defined? Does community for mental health require LGBTQ plus affinity groups and town halls on race and racism? If so, based on what evidence? The center claims that it is removing barriers to community by creating a place where everyone is welcome where they are. What are those barriers? What makes an appropriate place? How is the center enabling behavior? Does taxpayer-funded community require LGBTQ plus affinity groups and town halls on race and racism? This month's affinity group featured Love is Love. The center claims that its members have statistically significant decreases in depression, anxiety, and loneliness. How is this being assessed? Who is making the assessments? Clinicians use assessments to measure depression and anxiety. The center has no clinicians. Who and what are the qualifications of the persons making these assessments? Is it the program coordinator trained in DEI? The center claims that it is saving lives. What is the proof? The center advertises a number of programs. What evidence does it rely on in support of these programs? What data has it collected to measure program progress and effectiveness? How effective are these affinity groups and town halls? The center to open an ice cream parlor, it says it's for social integration. The property tax millage paid well over $20,000 for building it. What evidence does the center have to support this as a sound financial investment? What are the health benefits of ice cream for disabled people at risk of obesity? Or is this just a cash cow for the center? Frankly, why is the county funding a left-wing political activist organization? A sound financial investment is to use the $24,000 per month for basic services and housing for the most vulnerable in our community with developmental disabilities. How about an autism affinity group and town halls on receptive and expressive language? Thank you for your consideration of these matters.
Thank you, Stephen. Any other comments?
Rosalie Washington, City Hall. Good to see the Holland Full House, and I would like to see more presentation of what we are supporting with village funding. And was that January when it was either the drop-in center or was it the top house? There was something for financials and the police investigation. Which one was that? And then it's good. I can support the clubhouse, but if there's something going on with the financials, or maybe I'm mistaken in the drop-in center, but who's checking the compliance today?
Any other comments? If not, then we'll close out the comments and we'll move on to the consent agenda. Like a motion to approve the agenda as presented for today's meeting. So the March 27 meeting.
Hello.
There's the point. No comments or discussion on either. If not, all in favor, say aye.
Aye.
Same. We have a presentation.
Yep.
From Michelle. Vendor show?
Yep.
Vendor skill.
And I'm gonna, give me a minute to, where's my? Okay, I just-
Oh,
I am booting it up. Got you going, sister. Okay, let's see. Hopefully this will work. Okay, this. Rich. Oh, wait, here it goes.
right.
We might got it. We might got it. It's like, Rich. Yay. Look at that, first time. I know, right?
Well, I'll start. My name is Michelle Vanderstel. I've been with the county with CMH for over 25 years. And I oversee the MA adult program that provides mental health services to adults. Most mental health. They have a diagnosis of FMI, and they present with significant functional impairments in their daily lives. I have 66 staff right now that are providing services to approximately 600 clients that we serve in-house at our agency. And we have contractors in the community that are serving about another 200.
You see, next slide, okay?
For my programs, I have 6 program coordinators that oversee a variety of programs. And I listed them in no particular order. Our assertive community treatment program serves those with the most severe needs. They have significant diagnoses. They have a lot of case management needs, and they're seen in the community 80% of the time. So most of their services are delivered in their homes or somewhere else in the community. We have multidisciplinary teams here in Holland and Grand Haven, and those are made up of various staff. We have therapists, case managers, nurses, prescribers, peers, mental health aides, support staff. I'm always forgetting, but they provide services to people with case management needs, therapy needs, those sorts of things. And the team here in Holland is a little bit bigger, but the numbers are getting pretty close on both teams. One of those running North County and South County, and then kind of in the middle for the east part of the county. We have what's called a contract level of care team, and that was generally people that we used to contract out to, like a few different services and Arbor Circle. They are now, we do have some in-house staff that provide that level of care, but these are generally folks that don't have as many case management needs, mostly therapy and like crisis services falls under my purview. These are the people that are going to the hospital in the middle of the night to see their mental health crisis. And they provide crisis stabilization services. We have a program called Senior Reach that's in Grand Haven, and they serve a geriatric population. I should say geriatric. They serve the senior population. Those are folks that have mental health needs, or maybe like grief issues, lots of functioning issues, so different therapies. The other version is a brand new program. We're just start that. That's going to help us with people that are leaving jail, and as well as keeping people out of jail to begin with. We have current jail services for people with illness and substance abuse. We have clinicians stationed out there, there's a case manager out there, we've got tutors out there, and they're helping people with a variety of issues. We have a community intervention team, and this is one of the newer teams that we have. That includes a social worker with a police officer, or a sheriff. Definitely enable out and using the health call in the community. And that is a very successful, very well received program. Currently trying to expand that program. Those for case management and therapy, and they need just more. Services we provide a variety of things: therapy, case management, psychosocial rehab, which is what Bill was talking about with Clubhouse. We have peer support. As I mentioned, we do a lot of care coordination with other resources in the community. We have residential support with people in ANC. The majority of our folks, though, do live in independent housing. They live in their own housing at times. We have community delivered services. We try to do a lot in the community because people can't get here very well sometimes. We do medication treatment in the jail for people with opioid recovery disorders, and that people with mental health issues and pregnancy related services. This would be that information, practices. NPR, several staff trained in that. We see dialectical behavior therapy, and that's for somebody with a particular diagnosis. Things like it's designed for people with thought disorders, and it's a group setting for families and people. And then EMDR, eye movement desensitization, and I don't remember what the R means, but it's a very popular protocol for people with anxiety, post-traumatic stress disorder, lots and lots of use with vets, but it works really well for people with trauma. Yes. So when I get the numbers, I pulled this from our immune reports. That people with mental illness, the numbers are increasing, and that's just not an Ottawa thing, that's a national. You're not getting a lot more people to do. And the rate of people with substance use, I added the substance to the numbers last year. Because until a month ago, in addition to the mental health services that I oversee, I used to oversee the substance use disorders that this is a job. We've recently been able to separate that. But I thought I would just throw these in. We are increasing quite a bit in the last couple of years. We have seen a lot more people with substance use disorder. And I just like this quote. This is the one, probably, it's hard to say that anything good came of COVID, but one thing that did come out of COVID that was positive is that more people are talking about mental health issues and more people are seeking help for mental health issues. It just started more of a national acceptance of people reaching out to get help. So some of the strengths of my programs, we have really dedicated staff. We have low staff turnover. We have somebody retiring this week who's been here for 4 years. I have my program coordinators in time. I do have a very strong staff to meet the unique challenges of this population. The agency allows for a lot of training opportunities, which is great, which is why we can get people trained in the evidence-based practices. We do a team delivery of services. We don't have silos, so there's not a case management team, a therapy team, or a medication clinic. We do it all together on the team. So the clients have more than one person in order to receive treatment from. We can get a variety of services. We've had a lot more grant money. Oh, sorry. We have a lot more grant money over the last few years, and that's been great. It needs more staff, more services. A lot more increase in mental health and physical health integration. So there's been this huge push to identify the physical health needs of our clients because they tend to die a lot earlier just because of a lot of different complications. So we are integrating those two issues together and trying to help people become healthy in a more holistic way. We have a high percentage of staff that can work with the co-occurring clients, so people that have SUD and MI. And staff, we do a lot of surveys with staff, and they always say consistently, number one, the thing they enjoy the most is working with their teammates and with their clients. And the vast majority, like I said, of our clients, they live independently. So some of the challenges that we're facing right now, we had a lot more folks come to the door that housing is taking a huge effort on my staff's part, and people need it's a lot to try and find something for them. there aren't a heck of a lot of places that folks can afford. And when you get a disability check, that's maybe around $750 a month, and the rent is $1,200, and they want you to make 3 times more than what the rent is and you can apply for the apartment. It's really a challenge. We have a lot of people that are coming in the door that seem more symptomatic than I've seen in the past. A lot more of them on court orders, so they're involuntary for treatment. We have a lot more of what we call bottom tier Maslow needs. So they need housing, they need food, they need income, they need benefits, they need a lot of these lower tier things. And we're set up to do the treatment for the mental health, but when they don't have their basic needs met, it makes it a lot more challenging. I mentioned that we have a lot more referrals. There's a lack of longer treatment options, and that's kind of across the board, all across the physical and the mental health. A lot of our folks are getting older. I said that people with SMI have typically shorter lifespans than normal, but there is a population that's aging. And so when they need things like nursing home or like an AFC placement, those aren't readily available as easy as they were in the past. Lack of countywide transportation is an issue. I've got staff going to all corners of the county to try and pick up people for services or to get services to them. And staff retirements has been an issue. We've had several long-term staff over the last few years. Hospital bed at the state and local level. We are getting more beds coming. Plans for more child beds, there's plans for more adult beds, they're several years away. So unfortunately, sometimes people go to the hospital and they're looking for a bed and they might get stuck at the hospital for like 4 days, 7 days, something like that. And then, like I said, there's a overall increase in co-occurring substance use. So people have mental illness, but then on top of that, their SUV, we end up treating both, but it makes it a little more challenging for both disorders. And then there's a high competition for clinical staff. Like I said, I've been with the agency for 25 years. This is probably the hardest period of time that we've had looking for finding filling jobs for people with master's degrees and bachelor's degrees. And we're competing with everybody, right? So all my challenges.
Well, there's not enough paper. Thank you.
Oh. Well, please give me an email, my phone number, because I'm more than willing to talk to anybody if they have issues with loved ones or questions about how to get mental health treatment for somebody. Myself and my staff do a fair amount of that. So happy to get any kind of call.
Michelle,
Yeah.
you talk about 60 staff that we have in house that are serving 600 clients. Are those staff providing all the services across all 8 programs?
Yes.
So not in addition to a certain community treatment, they're also providing services.
Yeah. Patricia, could you pull up my
Yeah, I
real
sure
quick? It's under
can.
file server.
Sure.
It might be easier to look at the teams.
I could if my computer would work.
I don't for that. I do for like individual cases. Some of those staff are like the staff that are in my department. Some of them include like support staff and people like that who don't carry caseloads.
Those are in the 60. Okay, so those are
Yeah.
your administrators.
They're part of the teams. They support the team.
Yeah, for
So I
their,
have case managers that have like 57.
Yeah. for the staff who carry caseloads, they're up there. in the-
So one of the things I said, what I understood is just speaking on in terms of the assertive, you know,
Oh, yes.
treatment, you know, typical ratio would be 1 to 10.
Right, that's the.
That's
metric
just,
group.
that's just for ACT.
Yes,
Not to
that's
mention-
not like that. We don't have any kind of limits. So ACT has a limit. You can only have 10 clients per full-time staff that works with the clients. So you can't include everybody on the team, but you can include some of them.
I guess the point I'm getting to is we have staff that
Yes.
either involved in other programs. ACT, you're devoted strictly to ACT.
Yeah, they can only.
Eh,
And ACT has,
very
ACT has,
for the
like I
next
said,
one, though.
limits. Our MDT, our multidisciplinary teams, they don't have limits, so it doesn't matter how many staff I have, I can't turn away referrals. We don't, we're not with everyone. There's no wait list or anything.
Michelle, I have a question related to this. Is that okay if I jump in? On the number served, which was I just looked 65, is that, are those unduplicated? Is it a separate group with MI and separate group with substance use? That is it's a lot of people.
Some of those will be duplicates in the sense that, if we aren't able to meet their SED counts, you will have them go to Samaritas or to that.
Okay. So
Yeah. The majority of that number, though,
that 1,000
yeah.
could be in the 1,900.
Yes,
Okay.
but it's not.
It's still high. It's
Yeah,
still
not a
incredible.
whole lot. I mean, there's. This is my program and work chart. So these are the different teams. At the top, you can see that I have program supervisors up there. And at that's everybody. That's not an updated one.
This one I just pulled off of the,
I think it's the 4, 12, 20.
nope, I've got a 12, 13, and 11, 7 are the last
Under
ones
the
I,
file.
under the MI adult
Oh, no,
services.
Just under the regular.
Oh, okay. Let me pull that up. Ah, there we go. 4, 12,
Yeah.
23. Because I saw Joel was still on there too.
Yeah. I do have some people that are in blue there, that those are the people that were the SUV people and they're in the process of transferring out to a separate program. Yeah, see, some of the teams are a little bit bigger and some. are smaller. Yeah.
Oh, we have a question down here.
Yes,
So number of services, total volume. What that represents, or
yeah. So I think I said I have around 600 currently open, but our population fluctuates quite a bit. Like people come in and leave. And so
some may be 1 visit, some may be 5 visits.
Yeah.
What activities are you trying to services are going to be needed for an individual?
yeah, it's determined by their planning process, so the individual planning process, what kind of services you're going to offer. And how often they're seen, how long they're gonna be in services. And try to stick with that. With some of our involuntary people, we know how long they're gonna be in, because they're gonna be in until the order is done. But it is individual.
And you
So I mentioned that lower level of care, that contract level, some of those folks may come in, they have a couple of goals, they work on them, they get better, they go. Some of the people on ACT, we've had on ACT for 20 years. So it's just variable.
And KPIs, do you have key performance indicators that you use to kind of track to see how you're doing? And I'm suspecting that part of it will be hospitalization too, prevention hospitalization. Right, right. We actually had our UN meeting this morning and we went over some of those things. And we did see that our hospitalization rates are up. The length of stay is up. We've had a lot more people in the hospital longer. And there's a lot of that, but again, I don't think it's specific to Ottawa County. It's kind of a national trend. We're seeing people with higher acuity and it's taking longer for them to stabilize and get them out of the hospital. Any particular disease processes or it's kind of random. Sometimes they're not responding to the medications. Sometimes they're just not clearing up at all, even with aggressive medication treatment. Sometimes they have, like I was mentioning with the basic needs, we don't have a good discharge plan and it's not safe to discharge them to the community because they have nowhere to live and they're not going to make it in a mission setting. So there's a lot of different reasons that go into that, but we are seeing an uptick in those days for people staying there, as well as with the crisis stabilization, the crisis residential, I should say. There's more referrals to that, not necessarily, that's not really creeping up in terms of days, but. How long can they stay at the crisis residential? Typical stay, we try to keep it around 4 to 5 days. It's around 6 right now. All the time. All the time. Yeah, they were, every once in a while, they wouldn't use it during COVID just because of the disease rates and stuff like that. And then at one point it flooded out, but it was only down for a few days. They use it quite often. It's been very handy. Our partnership with Holland Hospital has been great. We are very fortunate to have a psych unit in our county, and we do place the majority of our folks that go inpatient at house if we can. They have a PIC. Not every inpatient unit has that. A PIC is a psychiatric intensive care for people with really significant needs on an inpatient unit that have to be separated from the general population. And a lot of hospitals don't have that. So when we're looking for beds, it really narrows, where we should find those. But Holland, like I said, we're fortunate to have that option here close. And we work very well with the staff. Cool.
Any other comments or questions? Michelle. Thank you, Michelle.
Thank you.
Next up is Amy Newbury.
Oh, you want to do? Okay. Okay, good. Then I will close this out. And I will stop my sharing.
Hello, while we're getting kids set up, I'll introduce myself. I'm Amy Avery. I'm the program manager here. Talk about and Skipperson Hennings, who's our compliance program coordinator. Then I also credential our staff and then external staff. And I also help with the audits that you will see that us and with our outside providers as well. With MDHHS or with the Lakeshore Regional Entity. And CART.
You should be able to, yep, go ahead.
Okay.
The 85.
Okay.
Should be 85. There's still the PD 85.
it wrong.
There you go.
I know.
He's got to hold the rabbit ears up, right?
Nature is no species. And then do you have window speed? And then.
Amy, it's in the packet if you want to go.
I'll see if I can get it going and then you.
All right, so I'm going to present the MDHHS annual data submission and needs assessment. We're required by MDHHS to do this annually. The needs assessment. Its purpose is to identify, examine, and evaluate the mental health needs of the county and provide a mechanism to track changes over time. And the typical components of this is the estimated full-time equivalents, which they also refer to as the FTEs, the requests for services and disposition of requests, waiting list, priority needs and plan set of actions, which they usually do a stakeholder survey every other year for that, the community data set. And for this year, for the components for fiscal year of 2022, which is the year October 1st, 2021 to October 1st, 2022 is the time period this covers. We had to do the request for services and disposition of requests, waiting lists, and the community data set. Now I will go over the specific data that we uncovered with this. So the total number of people who telephoned or walked in, we had 3,294 people. And the number of people that were referred out non-MH needs, mental health needs, was 357. And of those who requested services from CMH, there was 757 that did not meet eligibility through phone or other screening. And then of those requesting CMH services, there was 1,111 that were scheduled for an assessment. And then of those that were chosen for assessments, of the 1,111, 178 were deemed not eligible. They either dropped out, no showed, or they were referred out. And of those that were scheduled for an assessment, 21 did not meet eligibility criteria. And how many people that met the eligibility criteria of the 1,111 was 785. And of that number, there was 650 who met the immediate admission criteria. Then of the 1,111, there was 132 people that were put on a waiting list. And this was for children with SED, which is also stands for serious emotional disturbance. Here's kind of a graph of our school, how the process is done. It goes from the amount of people who phoned or walked in. So that started at 3,294. Then you can see like how many people who requested services, and then the people who are scheduled for an assessment. So you can see how the number is going down, and then the people who met the eligibility criteria, and then the people who met immediate admission criteria. Now I'm going to go through the data from 20 years to see how we compared. Year 2014, 2015, all the way to fiscal year 2016, 2017, it increased. And then there was a little bit of a dip, fiscal year 2017, 2018, and then it went back up and kind of plateaued between fiscal 2018 18 to fiscal year 2020, and then it kind of went back down this year, 2020 to 2021, and then it's going back up for fiscal year 2021. It's just a comparison of all the different service populations. It's separated out with adults with mental illness, children with serious emotional disturbance, and then adults with intellectual and developmental disabilities. So the green that you see in here is for adults with a mental illness. The red is for the children with this serious emotional disturbance. And then the orange and there is for adults with intellectual and you can kind of be able to, and it went up and then it went down. So year 2017, 2018, then it kind of slightly went back up and then went back down and this year 2020 and 21 and now it's going back up for the fiscal year 2021 to 2022. And you can see for children with serious emotional disturbances that it went down at the beginning from 2014 to 2016, but then it went back up all the way to fiscal year 2017 to 2018, where it kind of plateaued to fiscal year 2020, and then it really went up on an increase between 2019 all the way to 2022, as you can see on the graph in red. And then you can also see an increase with adults with intellectual and developmental disabilities, the increase between year 2014 all the way to 2018, and it kind of leveled off kind of similar to children with serious emotional disturbances. And then it took a little bit of a dip to fiscal year 2020 and slightly went back up to fiscal year 2021. I'm going to go over the community data set, just a little breakdown of all the data that we collected. So this year for the population, there was 3,680 Ottawa County residents, which is an increase of close to 7,000 from the last fiscal year, which is 295,874. And then for unemployment rate, we're at 3.3%, and that's a increase of 0.8% since fiscal year 2021. And as of February of 2023, we're at 3.5% for unemployment rate. And we're actually the third lowest in the county behind Oakland and Leelanau. This year for students graduating, there was 90.8%. This is slightly down from last year where there was 91.9% students who graduated on time. And there was 4.1% of students that dropped out for fiscal year 2022. 387 special education students graduated or they aged out in fiscal year 2022. In of our data, we saw that 94.21% of primary care physician is slightly down from last year, from the last fiscal year, which was 95.24% in fiscal year 2021. There was 3,855 children who were identified as at risk for severe emotional disturbance and are 100% below the poverty level for fiscal year 2021. There was 4,986 in fiscal year of 2020. And currently, they don't have the data for the fiscal year 2022. I'm sure we'll get that next year. And currently, CMH's consumers, 198 of them are homeless. In fiscal year 2021, there was 184. So there is a little bit of an increase there. And then also we found out that Ottawa County is ranked as the second healthiest county in Michigan, right behind Leelanau. That is it that I have for now. Is there any questions you guys have?
SED kids, that's increased. We have the staff capacity. What's the story behind this upward trend? Any-
children.
Huh?
We're just getting more and more requests for services.
Is it mostly autism issue? Is it
It's a lot of autism, but it's really across the board.
quite an increase?
Mhm.
With the national conversation about COVID and the whole,
Yeah.
and, the impact it's had on school kids.
Mhm.
Please.
The statistics, at least our statistics would seem to support that. When we talk about students graduating, special ed students, graduations, maybe a question for you. What kind of a relationship do we have with ISD? In school district? Work with them in
Mhm.
Transition.
Yep, definitely. We are in contact with the ISD several years before kids are graduating, young adults are graduating, so that we can provide as seamless of a transition as possible. So we work pretty closely with the schools.
136 words.
And that's still current.
It's still true in ours.
So it's important to know when we say waitlist, it's for a specific program, and it usually has to do with autism. So it's usually for the assessment, the initial assessment, or ongoing services like applied behavior analysis. We are serving those individuals in-house. They're just because there's a shortage of providers, they're not able to get a particular service. So it's not, we don't have a waiting list for anyone. We have a waiting list for some particular services because there's just not the capacity in the community to provide it.
What particular service?
It's usually, it's autism services. So it's,
Maybe, is it a lot of it? You said ADA.
yes,
assessment?
yep. So there's an initial assessment that has to be done. There's a backup in that area. Yep, and then there's also ongoing services. So applied behavior analysis, there's also a shortage of those providers as well.
But we've really come a long way with that, haven't we? I
Mhm.
mean,
Yeah, definitely.
we have worked hard to get more and more providers.
Mhm. We do
But we
is
still have those children out there.
Mhm. We are. Yep, they have to be certified, they have to have credentials in order to provide the service.
Any other comments or questions for Amy? Thank you, Amy, for the presentation. Next up, Rich. Our stopgap IT guy.
This is actually talking about data a little bit. So I'm here again to present the quarterly Nimbus report. I think I obviously presented this last week. I do have a stack of explanation for each of the indicators. If you need one again, I know I sent Patricia an electric copy of that so that she could send that out as well. If you wanted more detail on each of the measures. So we're looking at October to December 2022, first quarter in FY23 here. And you'll notice there was an improvement in terms of the dashboard itself. It's like everything is green except for that one red down below. And indicator 1, we're looking at the pre-admission screening disposition for inpatient psychiatric services 3 hours or less. For children, we got 100%. For adults, we were at 97.8, so above the 95% mark. So we're good there. Indicator 2A, we're looking at the biopsychosocial assessment within 14 days. And each of the populations are listed here. I'll remind again, we don't have an indicator yet at the state level for this. They haven't come up with the new indicator. So currently we have no benchmark for this. There's no target that we need to meet. But we do still track our data just in case they say, oh, this time you got to be at 60%. So we'll know where we stand. They haven't made an announcement yet. So those are the numbers there. It's pretty straightforward calculation for the percentage, just because the new indicators don't allow for any exceptions in the indicator 2 and indicator 3. Indicator 3 is ongoing services. So after they gotten their first assessment. There's the ongoing services that is needed, and that's another measure of 14 days after that. So that's what that's measuring. Indicator 4A, another indicator as well, percent seen within 7 days of inpatient discharge. We're keeping track of the children and adults, and we did 100% for each of those populations. There is still an exception in that calculation, so just something to keep note. It's explained in here as well. And indicator 10, which is the inpatient recidivism rate, we were out of compliance on the children's side at 33.3. The data for that, it was 3 out of 9. So we had a total of 9 people, so 33%. So we exceeded the 15%. I think what I'm gonna do moving forward is actually include a little bit more breakdown in terms of the data instead of just the dashboard. So some of the things that I've noted this time was that we actually had 772 total new requests for the quarter. So that sort of data to in terms of how many new requested services, and then breaking down each of the percentages in terms of the actual numbers. So instead of you guys just seeing the red, green, yellow. Any questions on them?
In the 33%, say this for children.
There was actually one individual that went into the hospital 3 times and came back in within 7. It's one individual. So we have to look at the cases individually. And, so,
That's treated as a recidivist.
and we actually have to do a plan of correction for each of those. So that's already been submitted to me. What we're gonna do is plan of correction. I think Ann's team was involved, so I have a staff Anna that works with the team closely to prepare the plan of correction, because they have to approve it and say, okay, you should try to get your numbers off and see what you can do.
It's unusual for us to not meet that standard.
Yeah.
We usually do.
Usually the one we do really well.
We must be more concerned about the person that get back into the hospital, the fact that they satisfy the state's desire.
Right. No, we definitely.
Right. I'm a little worried about the indicator 2 and 3 when they came out. They start looking at the data and there's no exceptions, and so everything is, what are you doing to address that? No, it's been longer. Been longer. So they've been at it for 2 years without a degree in 2 years. So they said they were going to release something in May, but haven't seen it. I did see the preliminary sort of target they were putting for, and I thought it was right on 95, but our numbers are also not that high either for now. Usually what ends up happening is when you finally have a target, then there's a different focus on it, and people are actually trying to meet it. All right.
Very good. Any other questions or comments for Rich? All right, thank you.
Thank you.
Here's the slide.
Uh,
Excuse me, my name is
In whole
Irma,
business.
and I had a question about the
It's
It was
someone
somebody else
online.
having a conversation outside.
any old business? Ray, are you okay with your answer to the question you had on the housing, how the housing costs recovered?
Yes, my part of the question was answered because I was looking at a particular. I had a particular question. Right, it was answered.
New business service contracts.
We're just gonna stay back here.
Okay,
For the new members of the board, my name is Kelly Getzinger, I'm the program coordinator for contracts and training. Thank you, Nicole. Because I subscribe to the goal of always hire people smarter than myself. This is Gina Kim, she's our contract manager, and he's here to also support and answer any questions. Sometimes we bring together, sometimes. We have two contracts on here today for you. First is personal accounting services. This is the new contract for fiscal intermediary. And they'll be providing management for self-determination budgets. That will be effective May 15th. The second is Tyson Health. They are also a new contract provider to provide transportation services. They will be providing transportation services for our senior consumers. With that client, that contract will be effective today, and will be using.
I have a, any discussion? Yes, Gretchen.
Is that the vehicle?
Yep.
Existing vehicles.
This is actually a service that we're going to enter into a contract with to help us with transportation needs for our consumers. So it's linking, they do things like they'll research and find Uber drivers, or really research the public transportation, the bus service, that type of thing, in an effort to help get our folks from their houses to appointments.
Coordinating.
Yeah. Mhm.
In contracting with this entity, do they have people that will be trained? Clientele that they'll be trained?
Yeah, they kind of specialize in really what they're most familiar with is working with hospitals to provide that kind of transportation, but they do, we will assure that they're not just any random. We wouldn't allow them
They're
to.
transporting an individual, not an individual should go into a seizure.
Exactly.
They're gonna know what they need to do.
Yeah. They're pretty well equipped with knowing the special needs for people who have health conditions. So we would definitely make sure that they're
Staff.
yes.
Any other questions or discussion? If not, all in favor of approving the contract? Next financial report. That you need.
Okay, I'm gonna stay here as well. And he got a financial man, teammates, and here with me, who's our financial manager, I will be. Members, the CFF committee has our statement of activities to the end of March, which is the first half of the fiscal year 22. We are still in good standing and in a good financial position in all of our funds. Mental health has a surplus of 5 million. We have that we are tracking both of these. We're just getting into the second part of the year. And, anticipating projections close to budgeted amounts and within our spending plan for year end. Surplus kind of diminish as we go through, get paid a little at the beginning of the year and kind of track that as the year goes out to make sure that we aren't having to return a bunch of dollars, and also on the good funding trajectory, so we don't have cash flow issues. Millage as well is in a good net position. We've started, slashing taxes through the first quarter of the calendar year, you know, based on tax payment made, so that we have slight surplus there. In the bottom right corner, again, total Medicaid funding, our anticipated funding of Medicaid dollars at this point, so very healthy position. Good, financially. Maybe somewhere helpful. Are there any questions? I guess if you.
I'll just move the budget after we do this motion. Do the amendment after we do.
Yes, yeah.
If we can have a motion to approve the financial statement. Support. Any discussion or question? None, all in favor, please. Aye. Opposed, the same.
Hi, everyone. My name is Mike. I'm the assistant financial manager. You may go over. As you can see, we have the 3 funds listed here, showing first column where we ended last year. So that's the prior year ending 9/30/22. Second column is the original budget that we began with fiscal year 2023. The third column is the current year amendments that have already been approved. And then the fourth column is the difference in spending or decrease in spending based on the different funds here. The 2 things that I'm going to bring to the board today are both related to the millage balance. The first is what was approved at the last board meeting, the community program. There's $70,000 for special residential, the $80,000 one-time payment to RPC, and the $90,000 payment for home. And those are both going to be funded out of fund basis. The next item I have is a new grant from NVHHS, specifically for CMH. It's called the Workforce Stabilization Grant. It is grant funding to be used for staff trainings and retreats to improve wellness and increase collaboration among CMH staff. It will offer continuing education credit, and the funds will also be used to increase visibility of opportunities for CMH, resulting in a larger applicant pool and a reduction of duration of.
And that grant amount is kind of.
Yep, it's $68,000 per year for up to 3 years. So we're looking at fiscal year 23, which we're currently in, and then fiscal year 24 and 25.
Are those divisions here?
No, they are not. So these are not, these 2 balances were not included. The top last column is listed in changes. Yep.
Is there specific criteria? I mean, or do you have a plan for this workforce stabilization grant or grant in the new plan?
No, it was, this is a grant that's almost exactly the same parameters as a grant we've had in the past. The other one was specific to our ACT team, our assertive community treatment team. They opened this up for other services for adults and kids with mental illness. So we're some places, some CMHs are using that funding to fund like retention bonuses or sign-on bonuses, and we don't do that here in the county. So except for those all-inclusive where the county does it all together. So we're using it primarily for the same things we did with the ACT grant, and that was to increase the recruitment efforts, meaning we're adding some emphasis to our Indeed posts and that type of thing, so that it's a bigger broadcasting, marketing. And then we're also able to use it for some trainings And as Nick said, some of our continuing education unit credits. So it's pretty much the same thing we were doing for the ACT version of this grant is what we're going to use the rest of the money for, the rest of the mentally ill and for adults and children's programs. Yeah, it helps. It definitely helps. Mhm.
So to make sure I understand what we're going to be approving, we'll be approving $68,000 for the workforce stabilization grant. And then the allocation of $170,000 from our fund balance.
Correct. Yep. So that'll be
80 to go to Parkview. I think it comes out of the mill.
Yep. And then the village fund balance summary. Is
A motion to approve the amendment as presented. Support. Any discussion or additional questions?
Didn't we already approve that? Didn't we, or are now, are you asking now that we take it out of this
Yeah.
fund?
So it was approved at the last board meeting to spend the money,
Oh,
now you're approving with
Now,
So
we're- now we're approving.
So I thought
Okay.
reinforcing that.
So
So
this is basically just a new budget of how it's done. These
This being brand new, just a question. What is the community partner program? Who is that?
Mhm. So, and the community partner program actually is the program we have to increase outpatient therapy services. Nick, I think you misspoke yourself. The name of the program is Specialized Residential Program that the funds for Parkview and Georgetown are coming out of.
Did we apply for that? Is that how?
Yep. Yep.
So it's not the community partner program. It's specialized residential
is.
program.
Yeah. Sorry about that.
So I think we need to amend our motion. Motion will be based upon as it's presented community partner program. And that needs to be changed to the specialized residential program. So we need a motion to amend the motion. Second. Everybody understand that? So it's what we are approving is not money coming from the community partner program, but from the specialized residential program. Clarifying that, I guess. Any comments or questions on that? All in favor of the amendment as presented, please say aye.
Aye.
The initial motion then is to approve the funding as proposed with 80K going to Parkview AFC and 90,000 to Georgetown Harmony Homes, and then the $68,000 grant for the work stabilization. All in favor of that motion as amended?
Aye.
All opposed? We have one.
Yep, the mental health village funding.
Yeah. If you and me.
Mhm. So this is, we come to every year and ask for the maximum allowable mills so that we can forward your support onto the board of commissioners. This is part of their budgeting process, and we've been prompted by fiscal services at the county to have this done here first. Since the millage was implemented in 2016, we've asked for the full mills. So that's the request. Do you have any questions? Sorry,
How many mills are?
it's for 0.3. Yep. It ends up being, because of Headley rollback, it's 0.2859. Yep.
Can I have a motion to approve?
Support.
Any further discussion or question? Favor say aye.
Aye.
Opposed? Motion is approved. Executive Director's report.
Okay, I'll give you some updates from the state first. We're continuing on that public health unwind of Medicaid. They've started doing the reassessments, and we've been keeping close track of where the numbers are. At the last meeting, I had shared that the Board Association had estimated close to, I think it was 40 million decrease in Medicaid funds due to that unenrolled, the change in enrollment. And they've updated that to looking at about a $28 million decrease. So that's good news. It's going the right direction. Nonetheless, there will no doubt be a change in the enrollments, and that's important to us for some of the new folks that are here, because our Medicaid rates are based on enrollment numbers in each county. So if we lose people off Medicaid enrollments, our Medicaid rates will be impacted. The department has assured us that they'll, through their actuarial service, Milliman, adjust rates as needed. Historically, sometimes they get that right and sometimes they don't get it right. So we're paying close attention to that. I'll keep you updated on that. We found out last week that our CCBHC grant, so stands for Certified Community Behavioral Health Clinics, that's one of our big SAMHSA federal grants. SAMHSA stands for Substance Abuse and Mental Health Services Administration. I've been telling the board for a couple months that the state of Michigan has their own, so there's two different types of CCBHC funding. One is through SAMHSA and one is through the states. The state program is called the Demonstration Program, and they let us know last week that that demonstration program is going to accept applications from all of the current expansion sites. So that includes us. And there's a pretty tight turnaround. There's a meeting actually as we're meeting today on some first steps for CMHs to start thinking about and planning as we move towards letting them know that we want to be part of the state project. I believe we can still, at least for the next round, we can still apply for the SAMHSA dollars as well. But that's something we'll have to research. The biggest change that's going to come with the state model is that instead of that grant dollars coming to us in lump sums every year, it will be paid out on a per person payment based on what services we provide for CCBHC. And it's the funding is pretty adequate to take care of the service delivery needs. It's quite complicated though when you try to figure that into how you're keeping track of the rest of our funds. We know that there's some difficulty just because some of the other CMHs, Muskegon, so Health West and West Michigan CMH are already involved in the demonstration project. And they've let us know that there's, it's definitely going to present some challenges to how we keep track of things. So we're all extra excited. I'm looking at Amy's face over there. About figuring that out, but in the long run, it will allow us to continue to provide more services to more people. So it really is the right direction to go in. So it was a little bit of a surprise. We knew that there were going to be some CMHs that were going to go to the demonstration project. We were hearing 4 or 5. But then we found out last week that it's looking like they're going to let everybody. And more than likely, most of those CMHs will get moved into the demonstration. I'm happy to answer questions about that if people have them, or if you want to contact me after the meeting, by all means I can explain more about that.
And you may or may not pursue the same one then, or you're going to assess 4 members, correct?
Yep, we'll have to figure out what that means for us at this point. We're not sure. But I will certainly keep you guys up to date if it looks like there would be a benefit to still applying for the SAMHSA portion of it. Some CMHs have done that. In fact, I think West Michigan CMH used their SAMHSA grant to help plan for the demonstration project. So I'll keep you informed. I don't know the answer yet, what we're going to do,
Annual funding of those.
Yeah. It will definitely, the demonstration grant for the CMHs that are already involved in it, the funding has actually been better through that part of it than it was through the SAMHSA grant. So we'll keep moving along from the Lakeshore Regional Entity. I've kept you up to date on the historical deficit, and I let you know that back in March, the judge that was overseeing the lawsuit, the DEC action, actually ruled in favor of the LRE and said that they could use their current funding to address the past liabilities. The work ahead of us will be to figure out how we're going to disperse those funds and make sure that we still have some left in our savings in case, it's needed. And to remind people, Ottawa CMH was not one of the CMHs that had that deficit issue going. It was 3 of our other partners. From CMH, again, welcome to our new board members. I've met with everybody in person except for Jason, who we did a Teams meeting. I realize that there is a whole lot to learn, and we're probably talking about stuff that doesn't make a whole lot of sense to you. I am happy to meet with people again and provide that information and education. If there's a presentation from one of our internal programs that you want to hear more about, all you have to do is ask and we will put them on the schedule. I'd rather you feel like you know what you need to know than feel really lost in these meetings. We continue to keep in close contact with our provider network. The program that you just approved, the budget amendment, the specialized residential program as part of our millage programming is an indication of us trying to pay attention to our providers and what their needs are. So that continues to go fairly strongly. We had a recent, we do twice a year provider network council meetings. We had over 100 people, providers come to that. We discuss things like billing issues, training requirements, give them updates on things that are coming up in the future. So that's always well attended. And I think it's a really nice way for us to stay in contact with all of our providers. I wanted to let you know that we got our results back from the Lakeshore Regional Entity Site Review. That was conducted from March 18th to the 21st. And we did really well on that. If you average the scores, we got about 94.5%. We did have some places where we need to write a corrective action plan, so we're already working on those. We had just on Saturday, a medication take back event. That's part of the DEA National Take Back Day. We had sites this time in Holland, Zealand, and Grand Haven. And I don't have the final numbers for you, but I'll give those to you as soon as I do. We usually collect several hundred pounds of unwanted and unused medication and sharps at those events. And obviously that helps to keep meds from getting in the wrong hands and looking at safety as well. We don't have our CARF dates yet, but they're coming up. They have to give us a 30-day notice, so it should be sometime in late March or June. And I wanted to let you know that we are hosting a community health fair on Wednesday, May 17th from 2 to 6 at Salvation Army, which is on Clover Street in Holland. And that is part of our integrated care efforts through our CCD grant. So everyone is welcome to that. You don't have to be a CMH consumer in order to go to those. So that's all I have.
Any questions or comments for them? Any general information, comments, meetings attended, anybody wishes to share? Please. If none, then we'll have our final opportunity for public comment. Again, if you can state your name and where in Ottawa County you live, township or city. And again, your comments will be held to 3 minutes. We'll start with our audience in the boardroom. Any public comments?
I live in Holland. I have 2 children that we adopted that have IBDs, but they're turned to you guys as commercial illness. And my son, who moved in with me 4 months ago, he's still alive. There's nothing out there for him. But we're trying to get him settled and figured out what to do. We have our first appointment with a psychiatrist. So that is good. But still, there's just no hope for him. And we now know how dire the situation in Ottawa County. We have another house guest right now too, who came the week before Easter. He's a 70-year-old vet. He has no place to live. He was living with a friend and then he had to leave there. He went to the mission. After 5 days, they were going to send him out in the middle of a thunderstorm. So he is sleeping in my living room right now. We're trying to, give him a safe place to do because he's a 70-year-old vet and he does have a Section 8 voucher, but they won't find any place for him. So after seeing this with Harold, I'm learning there's absolutely no hope for my son. So we're trying to figure out how to make that work. But one of my things is, dealing with CMH for my 2 adult children, I find it really confusing. Someone here, my daughter, okay, she has organic brain damage due to her brain being soaked in alcohol and her mom was pregnant with her. And then she also had a prenatal stroke due to the use of crack. But they don't take into account her IBD. They put her all under the mental illness thing. And I asked the CMH worker, what mental illness are we treating? She couldn't tell me. I thought, okay, this is helpful. And then we had our psychiatrist appointment with her, and they're treating intermittent explosive disorder. And they're expecting her to cure her brain damage and to be able to decrease this. And it's not working. It's highly frustrating for me and for my daughter. The phone call I got earlier, she called twice, she wanted to talk to me. Because it's just not working. It's not a good placement, it's not a good situation. There's really nothing. The only thing we can figure out at this point is we need to find a place for her and to implement our own program with CLS staff
to make her feel good. Because right now, I mean, she had a concussion in December from a housemate. Her roommate broke Michaela's wrist. And this is the best we can do. I just don't get it. But yeah, I find it really hard. And then I don't understand why when they're IDD and special ed and they don't have high school diplomas, she functions at an elementary age level, maybe third grade if we're lucky, but she's considered as mentally ill. And I'm sorry, but it's just getting frustrating. I had an appointment with my son with him, but with my daughter, it's like she can't heal her own brain damage. And what do I need to do to find something? I mean, she was born here in Ottawa County. We adopted her at 24 hours old and we had no clue. And we've been fighting for 25 years. I just need some help. But thank you.
Hopefully I've been having a video again. But your support, the part of the general. I need more specialized. Across the state, that there is a shortage here. How's it going with the ARPA funding training for our program in GRC to recruit ELS workers for South DT for also? That Iowa Area Center is shortening their summer school schedule program. They're adding more minutes to regular school year. So 180 families are more time off. They're gonna be stuck with no respite, no CLS, trying to access. It's gonna be quite these. Be their adjustment. No one. It's tough.
Hang our tag on to that because I have heard from constituents very concerned. I guess it's gonna be a week, a month that's gonna be taken off of school, plus that over the summer, you may know better, like 2 weeks of July and August. That sounds right. So very concerned. CMH has been offered up as some sort of support.
I can check into, we have a work group that meets routinely with the school. Beth's not here to give us an update on that, but I'll check into that. I'm sure they've been made aware if they're planning on changing their schedule.
That would be very helpful.
Mm-hmm.
Any comments from those folks that are online?
Hi, Jewel Wickman from Ferrisburg. May I speak?
Yes, Jewel, go ahead.
Hi, thank you. So I have just several questions. First, I'm requesting a breakdown of the dual diagnoses for serious mental illness, SUD, substance use disorder, medication, treatments. Are we looking at individuals with mood disorder and autism, sleep disorder and autism, depression and autism, suicide and tendencies? I listened to the entire meeting and we really don't have a grasp of what the problems are that we're seeing in the community. We hear crisis intervention, but we don't know what the crises are. So who are making these diagnoses on our children? Also, it's concerning that the board is being told that fringe benefits for staff are not included in Medicaid. Parents that self-direct services and even contracted agencies go through negotiations with CMH on community living support services, which is an all-inclusive billing code that includes staff fringe benefits, overtime, bonuses, training, anything that the individual needs, activities, that's all rolled into the Medicaid billing code. So I think the board should look into that. Also, Lakeshore Regional Entity has a customer services handbook that's 60 pages that details all the different supports and services that are per program that people have that are entitled to them, but that's not posted on our website. So no one really knows the supports and services, but that 60-page document of customer service handbook does exist. And I would request that it be posted on the website. Also, the Michigan Department of Health and Human Services provides home and community-based services to individuals in Medicaid program. These services help Michigan citizens with disabilities or other health issues to live at home in their community. There are children's waiver programs that offer massage therapy, recreational therapy, art therapy, music therapy. There are so many proactive programs that we can help our autistic children, not just ABA. And ABA is only for autistic individuals that are under 21 years old. What are we doing for autistic individuals that are over 21 years old? And also homeless. When you say homeless, are you talking about the individuals that are in adult foster care? I think that needs to be clarified so that the board understands when CMH says homeless, I think that they might be referring to adult foster care. And as far as the CCBHC clinic, certified behavioral health clinic, why are we using millage funding when we get millions of dollars in grant funding for CCBHC services? Thank you.
Yes, I was trying, may I speak? My name is Kira Rockman.
Yes, go ahead.
Yes. I had a question looking at the performance indicator dashboard. On indicator 4A, it said percentage seen within 7 days of inpatient discharge, and it had 100%. My adult child was not seen within 7 days of discharge. I just wondered if his information is included in on that. And it was within that October, December of 2022.
Okay, thank you. Any other comments, public comments?
And it's nice, there is the collection thing, but I didn't know we could bring it right there, so I see the box all along, so I didn't know. And waiting and exploring and playing around and waiting for one big event every couple months.
Thank you, Rosemary.
Follow up.
Yeah. All right. Once again, I'd like to welcome Donna, Jason, and Kyle to the board. Look forward to your participation, wisdom. Or else you can bring to the table to help us with. I have a motion to adjourn. So move. Ever say aye? Opposed? Thank you all.
Really good. Really good.